Very warm welcome to everybody on another episode of Breast Cancer Action Month, an initiative of IHW Council and Rapid Global Cancer Alliance being powered by Novartis. So, for today's discussion, the topic is on advancements in breast cancer detection, which is a new era in early detection. And to talk on more in detail on the same, we have very eminent panelists here with us. We have Dr. Sham Agrawal, who is Senior Consultant of Medical Oncology with Sir Ganga Ram Hospital, New Delhi. Sir, thank you so much for joining. We are so glad to have you with us. I welcome Dr. Geeta Manjunath, who is CEO of Niramay Health Analytics. Ma'am, thank you so much for joining. So glad to have you. I welcome Dr. Manjri Bakre, who is founder and CEO of OncoStem Diagnostics. Ma'am, thank you so much for joining. So glad to have you. I also welcome Dr. Shikha Panwar, who is Senior Consultant and Head of MRI Division with Mahajan Imaging, New Delhi. Ma'am, thank you so much for joining. So glad to have you.
Thank you.
With that, let us begin. So this is part of the month-long initiative that we are doing with Novartis, which is on the aim of raising breast cancer. So different aspects of breast cancer awareness are being discussed in different sessions. This session specifically talks on the advancements in breast cancer detection. So just checking if we have Dr. Sham with us, as my first question is directed towards Sir.
Yeah, I am here. Please.
Yes, sir. So, sir, to set the context for our audience, who are composed of from medical and non-medical backgrounds both, can you please touch upon the available methods for diagnosis of breast cancer that are readily in use in India at the current time?
Right. So the first thing to say is the incidence of breast cancer in our country. So which is rising, ever since, and currently approximately 1.75 lakh new cases of breast cancer are diagnosed each year. And this number is going to increase, in the coming years, maybe crossing 2 lakhs in 2030. So we have a huge problem at hand. And I believe actually there's a rise in the incidence of breast cancer in younger women. So which is especially so in the metropolitan cities. So currently the methods that are available for detecting breast cancer include, doing yourself, and followed by the investigations which are done by the experts. So I think the first thing is the breast self-examination, which needs to be done by each woman, especially after the age of 35 to 40 years, on a monthly basis. They can choose a time, for example, at the time of menstruation. And if they find any, change in the shape of the breast or nipple, or, anything unusual, dimpling, etc., so that should, raise the suspicion, and then they should go to a suitable doctor. The second way one can look at the breast cancer detection is a clinical examination by a local doctor, which could be a local gynecologist or a physician or a surgeon, which again, at least, once in 6 months, the lady should get examined. And if there is a suspicion by the doctor in the form of any lump, etc., I mean, that calls for, evaluation. So I think these are two simple things which any woman can do at home or in the vicinity by reaching out to a local doctor or a surgeon. Now, coming to the investigations, once there is suspicion or otherwise, when you're looking at screening, So screening mammograms, which is the X-ray of the breasts, both the breasts, is usually recommended after the age of 40 or 45 years on an annual basis or once in 2 years. So this needs to go on for the rest of the life of the person. And in high risk women who, for example, who have a very strong family history or who have BRCA1-2 positivity, then the mammography should begin 10 years earlier than the index case in the family. Say, for example, if somebody's sister had a breast cancer at 45 years, then the other siblings should start screening at the age of 35 years. Third is the MRI of the breast, which is usually not recommended routinely. But again, in BRCA1-2 patients, it is recommended along with mammography. So, these are the investigations as they stand today, which are routinely available and conducted in order to detect breast cancer early. And so I think we encourage women to sort of go and have themselves evaluated at periodic, intervals, especially after the age of 40 years.
Thank you so much, sir. We will get back to you with more queries on the same. But before that, I would like to ask a question to Dr. Manjari, founder of and CEO of OncoStem Diagnostics. Ma'am, if we have you with us. Yes. So, ma'am, we would like to know more what is the meaning of prognosis test? What is the importance, if any, for getting these done so that our audience is more educated? And how do these tests help the physicians in the treatment plan that they are planning, and also understanding what kind of tumor they have, etc.? Over to you.
Sure, thank you. Yeah, so as Dr. Sham already mentioned, screening is important and early detection is important. So once the cancer is detected in the patient's body, typical treatment for early stage breast cancer patients is, surgical removal of the tumor. Removing the tumor by surgery, followed by radiation, followed by chemotherapy, followed by hormone therapy. So, since breast cancer is one of those cancers, which is not, and when detected early, is not very aggressive. Prognostic test, it's important for the clinician and the patient to understand the aggressiveness of the tumor. That is, how will the disease progress, and then based on that, plan the therapy. So the tests that help the doctor and the patient understand how aggressive is the tumor, and based on that, plan the therapy, are called prognostic tests. So prognostic tests are not into screening or in diagnosis of the disease, but once the patient is known to have breast cancer and the hormone receptor mapping and a HER2/neu receptor presence absence is mapped out, that's when the prognostic test can help only those patients who have hormone positive, HER2 negative, tumors and early stage, to help plan the treatment after that. So after diagnosis. Now, how do prognostic tests help? Essentially is, some of the prognostic, the main aim of prognostic tests is to really understand the underlying tumor biology and based on which understand the risk of breast cancer recurrence. Now, always, what is important for the doctor and the patient is always, try to understand how aggressive is the tumor and will the cancer recur in that patient, because that's the part that is one needs to really be careful about, because primary tumor is always removed, but the cancer recurrence can be really, if it is metastasized to multiple tissues, it can be really fatal. So prognostic tests help, since they help you understand risk of breast cancer recurrence in the body. They definitely help you to understand which therapeutic modalities to choose in terms of chemotherapy or any additional targeted therapies. So prognostic tests really do not help you with radiation therapy. Hormone therapy definitely helps every patient. Surgery is required for I think almost all patients. So prognostic tests help you to understand the benefit of chemotherapy And if the patient has low risk of breast cancer recurrence, then the chemotherapy can be avoided. And now the hormone therapy is given for 5 to 7.5 years, and that is helpful for the patient to not have recurrence. On the contrary, if the patient has high risk of breast cancer recurrence, which is once again what prognostic tests tell you, these high risk patients not only will get chemotherapy, but can be candidates for additional targeted therapies such as CDK4/6 inhibitors, or if the HER2 expression is low, they could get Enhertu, and there are more and more newer drugs available. Those can be given to the patient right after finishing chemotherapy. So, the patient's risk of breast cancer recurrence is reduced further. And also this knowing the prognostication of the disease really helps the patient also understand the risk of recurrence, and help the doctor to monitor these high risk patients in a more meaningful manner. And so overall, it's a very holistic way of treating patients using prognostic tests. Typically, out of the 100 early stage hormone positive HER2 negative patients, 70 come out as low risk for breast cancer recurrence. So these 70 patients could potentially reduce their chemotherapy burden, not only the chemotherapy, but the side effect management, the cost associated, the toxicity of the treatment, cost associated of the patient losing wages, and also somebody coming with the patient to the hospital. So there are many such issues that we face, which could be avoided for the patient as well. So that is in short what prognostic tests are about and how do they help in treatment management.
Thank you so much, Dr. Manjari. Thank you for so nicely explaining. We will come back to you with more queries. And before I move on to Dr. Geeta and how her latest technology is benefiting the women, I have a question for Dr. Shikha. So, ma'am, we would like to understand more on what are the gaps that you feel that, are there in the detection methods that Dr. Sham has, elaborated, and that are widely most commonly used by clinicians in the country, and for detecting all types of cancers in general, but also talking about specifically for breast cancer detection methods. If there are any gaps that you feel that research and technology would be required in future around these areas.
Hi everyone. So by gap, the biggest gap in our country as far as breast cancer or in general any cancer is concerned is awareness. See, the urban population, the population which is in the metros are still aware of these issues, but our large population which is in the tier 2 and tier 3 cities and the rural population, there is very, very limited awareness. The methods that Dr. Agarwal has mentioned about breast self-examination, clinical breast examination, if these are adopted by people, by all of the population, then they will come forth with their symptoms very early. As of now, our biggest problem as we compare ourselves to the West is that we have cancers coming to us in stage 3 and stage 4, which are very large stage. And then to help those people with treatment and management is a very difficult task. So that increases mortality, puts a huge financial burden on the patient and on the state as well, for both. So the biggest gap is creating awareness. And thanks to people like you who have these programs and these panel discussions, more and more people are getting aware. They are at least aware of what is available to them. What are the facilities that are available to them? Then the next thing I think is access to medical facilities. Again, in urban areas, metro areas, there are hospitals and clinics and these facilities, medical facilities easily available. As you move further away, access to medical facilities, access to even doctors is very less. We have very few doctors per 1,000 people available. So access to medical facilities is another one. The third thing, what I think where the gap lies is availability of equipment. So when we talk of breast cancer as such, the basic thing that is needed is a mammogram. And there are very few facilities which actually have a mammogram of a particular quality to detect cancers early. So availability of equipment like a mammogram is also, fairly low if we move out of metros, and of trained doctors to read these mammograms to a particular level. We have all sorts of people reading the mammograms, assessing them, missing cancers. So lack of trained staff, lack of trained doctors in these particular niche areas is also a big gap. So I would say, all in all, awareness, access to medical facility, availability of medical facility, that is equipment, and availability of trained personnel, trained doctors to assess all of this.
Thank you so much, Dr. Shikha, for so nicely explaining us. And you pretty much covered all points that we have been hearing around breast cancer that require attention and focus. My next question is to Dr. Geeta Manjunath. Ma'am, through Niramai Health Analytics, you have been doing great amounts of efforts for breast cancer screening and detection. Can you please highlight some of the advances that you have been leading and how this can benefit the women that are watching?
Sure. Congratulations to you and Novartis for sponsoring this event. And because it's at the right time, as many of them know, October is a breast cancer awareness month. And as Dr. Shikha said, you're doing a wonderful job in creating this awareness in the public. And I think, as my previous panelists mentioned, breast cancer is a major issue that needs to be solved, not just for India, for the whole world. 684,000 women die every year. And so many countries, including India, have 50 to 60% mortality rate. Every alternate lady detected with breast cancer is dying within 2 to 5 years. How can we stop this? Yes, we can stop, because breast cancer is completely curable. You have, pharmas like Novartis, who's actually developing newer methodology to detect, to treat. The only thing is that people have to come early. And as Dr. Shah mentioned, most of the time people are detecting, and the only screening that they can actually do is hand examination, either themselves, or that is self-breast examination, or going to an ASHA worker who is like half trained on clinical breast examination, or a real gynecologist or a physician who can do it. And also, as Dr. Shikha mentioned, right, access to mammogram is not very common, definitely in rural areas, but also in urban areas where people have to travel a lot and figure out where to go. And also, she talked about the gap in the skill needed to perform a mammogram as well as interpret, right? So all of this given, and so one other point I just want to highlight, what Dr. Shah mentioned, is that in India, particularly, more and more younger women are getting detected with breast cancer, which is unfortunate. But India has two peaks in the age, right? When we look at breast cancer incidences between 30 and 40 and 50 and 60. So which means there's today no test to detect early. For younger women, definitely not. And for elderly above 40, 45 who are qualified to go for a mammogram, also there are other issues that we talked about. So in this scheme of things, what Niramai has done is to develop a new method of detecting breast cancer by combining a simple technique of thermal screening with artificial intelligence. So we use a infrared imaging device to measure the temperature variations on the chest. We measure about 4 lakh temperature points per person, completely non-invasively, and analyze this temperature distribution to say whether there's an abnormality or not, what is the probability that abnormality can be cancer, and also mark the likely area of malignancy so that a follow-up diagnostic workup can be done. It can be a wonderful screening tool for people who are not able to access a mammography machine, for example. Almost 90% of India doesn't even go to do a mammogram. In fact, 2 to 3% only go for screening mammogram today. So that's sort of a huge. Second thing is it's completely very, very affordable. So we have 2 types of screening. One is simple triaging, a red, yellow, green for rural areas where you can do it at 100 rupees per scan. And also in a hospital setting where you have detailed reporting with radiologist review and signature, which can also be done at a very, very fraction of the cost of what's available today from an imaging standpoint. Accuracy standpoint, also we've done several studies now and published in top publications saying and showing how this is non-inferior to standard imaging modality. In fact, it is much more accurate than current methodologies, especially when you consider dense breast, which is usually seen in women under 45. And about 50% of women above 45 also tend to have dense breasts. So this is what it is. And finally, last but the best is the experience of doing the test, where it's like a changing room experience. The lady enters, she closes the door, and then removes her clothes. Nobody is inside. It's like a passport photography session, but no photographer inside, right? So you go in, sit in front of the device for about 10 minutes, and cool air is blown for about 5 to 8 minutes, and then imaging is done. And the images are uploaded to our software to actually generate a quantitative report that can be reviewed by a radiologist or an oncologist before handing it over to the end user. So this is what we have developed. I'm happy to share that more than 1.5 lakh women have benefited so far, and we have received both European and US approval, in addition to, of course, India and several other countries in Asia and Africa.
Thank you so much, Dr. Geeta. We have many more doubts, but before coming back to you, I will take few questions from other panelists as well. Dr. Sham, if we have you with us, I have a question for you. Yes. So, sir, as it has been, as we are discussing the different types of breast cancer detection methods, it is pertinent to also discuss if there are, different types of breast cancers in themselves, so that people are made aware if there are, multiple types of breast cancers that occur. If you can elaborate what those types are, and if typing is important, because up till now, what most people understand is the staging of any cancer, that stage 1, stage 2, last stage. They understand that, and they understand that, which part it suffers. And when it comes to breast cancer, some people also understand that, it is either hereditary or it's in their own that they have, and no genetic history is there. So if there are other aspects in the types as well that you can explain us.
Right. So, yes, I think several types of breast cancers, which we can two features. One is as the pathologist looks into the slides of the tumor specimen, so they can tell us whether it is an invasive cancer or not. So, which is not otherwise specified, is the commonest one. But there are certain other types of breast cancers, like lobular carcinoma, like papillary carcinoma, or mucinous carcinoma. So I'm not going to the details of those, because the latter 3 or 4 are quite less common. The commonest is the invasive breast cancer. But I think more important is the type of breast cancer, which is based on 3 important tests. One is, first is estrogen receptor, second is progesterone receptor, and third is HER2/neu gene amplification. So these 3 tests are performed in each patient's biopsy specimen to figure out that which of the 3 types of breast cancer the lady has. The first one is hormone receptor positive, in which estrogen receptor and or progesterone receptor will be positive, and HER2/neu amplification will be negative. The second type of breast cancer is HER2/neu positive, which means that you do the test of HER2/neu gene and you find it to be 3+, or FISH test is done to figure out whether the patient has HER2/neu amplified breast cancer or not. So if all these 3 are negative, which is estrogen receptor, progesterone receptor, and HER2/neu gene amplification, then this breast cancer is called as triple negative. So this distinction of, ER positive, HER2/neu positive, and triple negative is extremely important, because it has a bearing on the treatment, not only in the early breast cancer, but also in the metastatic breast cancer situations. So, for example, estrogen receptor positive is dependent on hormones, and you treat them with several hormonal drugs which are available today, like tamoxifen, aromatase inhibitors like letrozole or anastrozole, exemestane. And then we do have CDK4/6 inhibitors like abemaciclib or Crixana and palbociclib. So similarly, for HER2/neu positive breast cancers, we have drugs like trastuzumab, pertuzumab, lapatinib, and actually the list is growing so much that you have to really decide which drug is to be given for HER2/neu positive patients in which condition, whether it is early breast cancer or metastatic breast cancer. And third is the triple negative, in which all these three tests are negative. Then there is an emerging role for immunotherapy drugs. So when somebody has triple negative breast cancer, since you raised the question of BRCA1 or BRCA2 positivity, so BRCA1 and BRCA2 are genes, which are found to be abnormal in patients who have a family history of breast cancer, or especially who are young with triple negative breast cancer. So it's a blood test, or one can test in the saliva, and it is not very expensive, 10,000 or so per test. And the report comes in about 14 days or so. And if the test is positive, then it has implications on the patient's treatment, because we have new drugs like olaparib, which can be used in early breast cancer, high-risk patients, or in metastatic cancer, which is advanced breast cancer, in the metastatic setting in the second or third line. And of course, if somebody is BRCA1/2 positive, well, then she has a high risk of developing opposite side breast cancer and ovarian cancer and even pancreatic cancer. So if somebody's, has a breast cancer and turns to be BRCA1/2 positive, then there is a role for genetic counseling for the family, especially the women in the family, because they also need to be told that BRCA1/2 testing should be done, especially if they have a strong family history. So I think the Angelina Jolie's story has, taught everyone across the globe the lesson for BRCA1/2 positivity, in which she underwent removal of both the breasts as prevention, and then subsequently ovaries for preventing the occurrence of ovarian cancer. So I think the other distinction in types of breast cancer is whether an individual has early breast cancer or metastatic breast cancer. So as I think was told earlier, early breast cancer, if detected, without any metastasis or distant involvement of the organs, then it is curable in almost 90-95% of the patients. Whereas if somebody has advanced metastatic breast cancer, which has gone to the bones, lungs, liver, etc., I think we have tools today, we have medicines today with which people can live going beyond 5 to 10 years. So, we have chronic disease. So one should not be scared wherever they want to take treatment, that what new drugs have come in so as to get the best from the pharmacy available.
Thank you so much, Dr. Agrawal, for so nicely explaining all the different types and the different aspects around the types of breast cancers that are available. My next question is to Dr. Manjari. Ma'am, as we understood from Dr. Sham that there are so many different types, and as you rightly mentioned before, that identifying the recurrence aspect around breast cancer is also very important. Can you please also talk about how OncoStem is helping in this context, and what is can assist breast, and how that the role of that aspect comes in detection aspect of breast cancer?
Sure. Yes. So, as I think now the audience knows that prognostic tests help you to understand the tumor biology of the tumor that you have, and based on whether it is aggressive or not, treatment can be planned. Now, prognostic tests OncoStem Can Assist Breast is the name of the prognostic test. Can Assist Breast. that has been, so OncoStem was incorporated in 2011, and it took us 5 years to develop CanAssist breast. It was developed using our patient, that is Indian patients' tumor tissue samples, and it's been in the market for last 6 years, since 2016, to predict the risk of breast cancer recurrence for early stage patients, and it's been helpful. So what CanAssist breast essentially does is, it segregates the patients with early stage hormone positive, HER2 negative patients with up to 5 centimeter tumors into two, based on the tumor biology, into two categories. Those who 70% who have a low risk of breast cancer recurrence, and 30% have a high risk of breast cancer recurrence. So these high risk patients definitely need chemotherapy, better follow-up, and also additional drugs as and when the clinician thinks the patient is fit to take, a patient needs to take. And the low-risk patients can forgo chemotherapy, but will certainly need the radiation and the endocrine therapy that is given to the patient. And so the biggest issue of use of prognostic tests in India until our test came was, the prognostic tests have been used in the West quite often. They are in every guideline, but they cost, the cost is prohibitive. It costs about $4,000 because those countries also have insurance coverage, healthcare, so that those insurance would also cover this test. However, so those tests are not ideal to be used outside of where there is no health insurance to the patient. Patients are paying out of pocket, and also those Western tests have been developed on Caucasian patients who have disease onset at a later stage, and disease onset diagnosis at a very early stage, like 0.1 centimeter, 0.5 centimeter tumors, etc. So in terms of biology of the tumor, our patients have slightly bigger tumors, 2 centimeter tumors, and the incidence can be early, as Geeta mentioned. Between 30 and 40 is one peak, and then later also. So CanAssist breast covers essentially this aspect because it was developed on our patient. It looks at the tumor biology of a slightly bigger tumor and of a patient who is diagnosed earlier as well. And therefore, we feel it's the ideal test for Asian patients where the incidence of the disease is early. Now, having said that, cost is, of course, CanAssist breast cost fraction of a cost of the Oncotype DX or any other Western prognostic test. So since launch of CanAssist breast in the market since 2016, we have more than 4,500 patients have been treated based on the outcome of CanAssist breast test done on their patients, their tumor samples. And we have saved chemotherapy, via the test, of course, for about 70% of the patients till date. And now, so since we have finished 6 years of being in the market, being this thing by the bedside, we also have our own data which patients took CanAssist breast, avoided chemotherapy, and how are they doing today. We try to follow each patient annually, and it is one thing I can tell you, Dr. Asavar, is it is so heartening to see that those patients who did not take chemotherapy in 2016 or 2017, who have finished 5 years as on date, when they do well and they give us testimonials that we are doing well. We have had a patient who went ahead and had baby instead of having chemotherapy, and she's a happy mother of 5-year-old. We have had testimonial from a rickshaw driver's wife that because of your test I saved chemotherapy, I was not given chemotherapy, I am doing well. A person who runs juice center, his sister has given a testimonial. So essentially, what I'm trying to drive at is a CanAssist breast is really meant for our patients who are middle class, lower middle class, who cannot necessarily afford the Western prognostic test. So that is how I see that CanAssist is helping patients, and OncoStem is impacting and helping the breast cancer patients. And our goal is to really, we have also treated patients from Sri Lanka, Bangladesh, and Middle East and UAE, for example, Turkey. We have been doing business with them. So all of these patients, all of these clinicians always tell me, oh, can we send you samples because our patients can't afford the Western test. So will you be able to test our patients' tumor tissue? So that is really the goal, to really market in those geographies where the Western prognostic tests are unaffordable, And our test has been validated in most of these geographies as well to work equally well.
Thank you so much, Dr. Manjari. I have two follow-up questions, which one I will be taking from you, another one I will take from Dr. Shikha. So one of the questions that we would like to understand is from a prevalence point of view, how many people usually that suffer from breast cancer or, develop breast cancer do have this prognostic type of breast cancer or are detected with something that would or a recurrence of breast cancer out of the entire thing, so that we are able to understand how many people are suffering.
Yeah, I'll just take a dig at it, and Dr. Shikha can also discuss. So typically from the statistics known today, in India, about 1.8 lakh patients get diagnosed per year, new breast cancer patients. And as you know, Canas's best is done only once any prognostic test is done only once in the life of the patient. And out of these 1.8 lakh breast cancer patients, Canacyst or any prognostic test is only meant for early stage hormone positive, HER2 negative patients after the surgery, before the decision on chemotherapy and other therapies. So it is only meant for early stage, and early stage hormone positive, HER2 negative work out to be, we are talking about stage 1, stage 2, and very select stage 3A patients. So that's about 40 to 45% of the total breast cancer burden we see in India on an annual basis. So that's the number. So after 1.8 lakh, we are talking about 40 to 45% patients who are eligible for doing prognostic tests. And based on the prognostication, they can plan treatment.
Thank you so much, ma'am. That gives a better clarity to all the audience that is watching. Another follow-up question that we would like to take from Dr. Shikha is, ma'am, as our esteemed panelist, Dr. Geeta, Dr. Manjari has emphasized that these different tests that have been developed for detecting breast cancer are specific to Asian population or Indian population. So can you please help us understand what are the major differences when it comes to breast cancer in Caucasian population, Western population, where we have lots of research on this aspect, compared to Asian population, differences in breast cancer?
Yes. So this is a very good question. And I will start first and foremost by saying that the major difference between the Western population and the Asian population is the age at which cancer presents. So very typically, the Asian population, the age at which cancer presents is about a decade earlier than the cancer presenting in the West. So in the West, it would typically be, 60 to 70 as the age, whereas in our population, it starts, I would say 40 to 50. So almost a decade earlier than the population in the West. So this is a very, very important factor. Then the other thing is the type of cancer. There are specific types which research has now shown is the more prevalent cancer in Asian population. One of them being the triple negative breast cancer, which Dr. Sham Agarwal explained very well. This is the cancer in which all three immunohistochemistry markers are negative. That is the estrogen receptor, progesterone receptor, and the HER2/neu. These three are negative. It's called triple negative breast cancer. And funnily enough, triple negative breast cancer is one of the aggressive forms of breast cancer. Amongst the cancers, you have cancers which are the better cancers because their prognosis, their recurrence, this is all better. And you have another which are higher grade and more aggressive. So triple negative breast cancer is the more aggressive kind of breast cancer. And typically in the Asian population, it is more common to have triple negative breast cancer as the type of breast cancer. So these two things are the difference between Eastern and Western. And the other thing which I've already spoken about is we typically have cases which come at stage 3 and stage 4. Our people with early stage breast cancer, which is stage 1 and 2, where the tumor size is smaller than 2 centimeters, is lesser than in the West. In the West, patients come with earlier stage breast cancer. So that is why their mortality and morbidity associated with breast cancer treatment is lower. than in our case.
Thank you so much, ma'am. We have one more query that I would like to know from you. That as you said that in Indian population, mostly people come up at last stages, 3 or 4, and compared to Western population, where people show up and are able to, and the cancer is able to properly present itself at earlier stages. So is it something with how our food culture and lifestyle is in India, that at early stages the cancer signs of breast cancer is usually masked, or does it simply the negligence of people that they fail to recognize any sorts of tumors or lumps at the early stages? What is your experience?
Again, a very good question. So it's not that cancers over here are present differently or cancers in the West present differently. It is totally why our population comes at a later stage is totally, like I said, awareness is not there. Access to the patients are not aware what is wrong with them. They say they are in denial. They say dard to hua hi nahi. There's been no pain. They are not aware that typically cancers do not present with pain. So they are not aware of those symptoms. Hence, they do not come at an earlier stage. Plus, we have in our society a woman who brings the family together is last on the priority list. She will make sure that everybody else is looked after. As far as her symptoms are concerned, she will keep ignoring it and putting it in the back burner. So basically, our people come late. Then in the West, they have screening protocols for which the government pays. So patients are bound to come for screening, hence their cancers get detected early. We in our country have no screening program. So nobody is bound to come and get those screenings done. For any cancer, not only breast cancer, if you want to detect cancer early, you have to be on a screening protocol. You have to come and get your screening done. That is when you will catch cancers before they can form a symptom, before they can form a lump, before they can present as a discharge. So you have to be on a screening protocol. We do not have any screening protocol. So till such protocol is incorporated in our country by the government, we have to just create awareness so that patients know that above a certain age, they have to come and get screening done. They have to be aware. People who have hereditary breast cancers have to come at an earlier stage. So these are few factors. Another important factor is availability of tests. We now have very fantastic technologies, imaging techniques which detect cancer at a very preliminary stage, at a stage which is pre-malignant. The cancer has not formed, it is likely to form. And if we detect cancer at that stage and act upon it, it is treatable. You will forget you had a cancer. Those are in situ stages. And we now have modalities like 3D mammogram. It's called digital breast tomosynthesis, a 3D mammogram. We have very high-end MRI equipments who will detect cancer before the invasive component of cancer before it is formed. It is likely to form an invasive cancer in future. At that stage, we can detect. But people are not aware that we have those facilities now available. Any facility that is available anywhere in the world is now available with us in India, in Delhi, but people are not aware and they do not come to us. That's the only reason why we are detecting cancers late. Nothing else. It doesn't have to do with the cancer, that the cancer presents differently here. It's the people.
Thank you so much, Dr. Shikha, for so nicely explaining it. We will come back to you, ma'am. Before that, I have a question for Dr. Geeta. So, ma'am, as you were sharing about this screening tool with Niramay that can be, that can be used for women in the remote areas as well, we would like to understand more that is it specific to only breast cancer detection, or will it help in detection of other types of cancers as well? Is the work being going on right now, or is it already executed and you are able to detect early cancers as well? And how can that be translated to a more wider population, I mean all across India, if we would want to use this?
Sure, thanks for the good question. I'll answer the second one first. Building on what Dr. Shikha very nicely explained, right? It's the people. How do we reach the people in an affordable, accessible manner so that they can actually do it as a screening? Whether there's a symptom or not, they need to go and do the test, right? So that's most important. Getting that into their habit, making women health a priority, etc. So all this is very, very critical. To address this need, right? We have started to work with government to actually see if it is possible to do a population level screening. We've been successful in 4 or 5 states already. So I'm very happy to share, for example, in one of the states, we've screened about 12,000 women just with 2 equipment going around. And then we were able to stream down to, just about 300 people who had to get to the next level, right? So these kind of, making sure the right kind of people are instantly identified to go to the diagnostic workup that is needed through all the wonderful imaging methodologies that are available today. So that is one thing that we are focusing on. We are also focusing on how can we include this in annual health checkup in urban and rural ecosystem, be it in a hospital, be it in a diagnostic center, with or without mammogram. Even if there is a mammogram, many people are not able to include that in the annual health checkup because of the cost and all of the other aspects involved and the young age and so on. So we could actually add this as a part of the annual health checkup, basically screening to identify abnormalities very early. We are able to detect stage 0 abnormalities as well, even DCIS, fibroadenoma that Dr. Shikha was mentioning. So this gives us a good way of identifying and making sure that we address the population who needs to be addressed, right? The population who is not coming regularly for doing the screening, and identify those who better come now, right? So that has been our, and it's not just in India. We've received a tremendous interest and already collaboration in Philippines, Malaysia, to do in Indonesia, UAE, Turkey, Sweden, Bulgaria, Denmark, and all of these places, including US, we just started with 2 doctors so far. So this is spreading. So of course, in a developed country where there is excellent access to good infrastructure, this is still useful as an additional modality to detect abnormalities in dense press, which is still continues to be a limitation. And having said that, in countries like India and the developing countries, we are focusing on large-scale population level screening and annual health checkup. And I'm happy to share on this forum, and probably you will hear in the press note later this week, about a partnership with a very large organization, which is allowing us to take this to 86 other additional countries as we speak. And we're happy to launch this to all of these 86 developing countries. So now, as opposed to your first question about is it applicable to other types of cancer, I hope and I wish, and the technology can, do that. But at this point in time, I'm unable to claim anything beyond breast cancer, because that is where we have done 5 clinical studies and fully systematic, blinded, prospective studies, and published 36 papers on it. For other type of abnormalities in the body, yes, we are working on a full-fledged body scanner as we speak, and then we have applied for regulatory clearance. We hope FDA will be kind enough to give that, and once that is done, we go get into the market. Yeah, thank you.
Thank you so much, ma'am. Before we let you go, I have another question which I wanted to take later on, but as you already mentioned about FDA clearance, etc. So we wanted to know what are the most significant policy and regulatory considerations that need to be addressed to facilitate the integration of these advancements in these newer technologies that you are also part of in breast cancer detection to standard clinical practice. I mean, how far do you see this, being in years aspect? When do we would be able to see this readily being used everywhere and all over, as per your
Yeah, in India, you're asking, right? The policy changes in India. Yeah.
Yes,
so as I mentioned, there are certain regulatory bodies who have special life cycle review and procedures for AI-based medical devices. So one thing I did not mention so far is the fancy term AI, right? The artificial intelligence space. Definitely, Niramai test called Thermalytics is enabled due to machine learning and artificial intelligence on large amounts of data that's coming in from a thermal scanner. Having said that, when we talk about the device itself, it's called software as a medical device. Means it's basically just a thermal scanner is literally just a temperature measuring instrument, and you can't do much about with it. Only when you add this smart software, which is AI-enabled software as a medical device, that's when it becomes a medical device for in this particular case, breast screening. Similarly, of course, there are people who have developed wonderful such tools for eye, triaging of eye diseases and lung cancer, possibly, and so on, right? So this is an emerging field of software-based medical devices, where even US FDA has very, very strong ways of how it has to be developed, how it has to be tested, how it has to be deployed. Similarly, with the European CE regulation. In India, it is just in a very initial stage. Initially it was software was considered part of the hardware. Now they do support, and Cidesco has a very, very expert panel now. They've started reviewing, and definitely more effort towards making that standard. So once we talk about software, then comes the data. How do we treat the data associated with from the patient, anonymized, sharing, all of those issues? So these things requires a little bit more beating, I would say. And I've been part of many of those forums giving feedback, and I'm also part of it, right? I also own this responsibility in that sense when I say it has to be done. It has to be done by all of us to create right policies. It is very, very important for users, the hospitals, diagnostic centers, to just not take a device developed outside India, not necessarily is better than a device developed in India, just because it is Pirangi, right? I'm so sorry, I have to say this. You better see the clinical results. Better test it on your own data, no worries. Better see the clinical results, right? And whether it was a prospective study done, what was the size of the study, whether it was tested in the field or tested in the lab. These things have currently, because it's not very much part of the regulatory system, it has to be sometimes part of the healthcare, the companies which are adopting newer technologies. The second bit I want to say is also about there should be some incentive provided to the hospitals and the clinicians, to participate in research trials. It's really hard to find people who can continue all the way. They do some 100 patients done. It doesn't work that way, right? 100 patients, one cancer is absolutely no study, right? You have to have a really good, interest in doing clinical studies, which you can do for 700,000, 10,000 patients, and then look at good number of positive cases before you decide whether the device works or not. So some people try it for small number and say, oh yeah, kaam nahi kiya. Aise nahi hai. Because the number of instances, though it is very large, the number of breast cancers, when you actually look at it as a clinical study, do 100, you probably will find 1 or half a person having breast cancer. So that is not a sufficient evidence to determine sensitivity specificity. So I think more and more trust in clinical research and how, and I'm giving some incentives to both doctors, imaging centers, or hospitals to participate in this. And if possible, some funding for the startups to do it would be extremely helpful to actually develop many, many innovations in this. Particularly AI-based devices have huge benefit and prospects more from need and the availability perspective, because India is an IT capital of the whole world, at least one of the top 3, right? When that is the case, there's so much talent we can develop. But yes, we need to have good amount of partnership between tech and medical field to actually make real newer and newer devices possible.
Thank you so much, Dr.
That's my 2
Ida.
cents.
And definitely, ma'am, you shared some very real aspects around all of these technologies related to healthcare in India, very real aspects from the execution point of view, from leading point of view, and also from, as we can see, the Make in India initiative also being, pushed to a higher extent. I hope in future, more and more people will adopt these India-made technologies and India-made devices, as well as drugs and all different areas in healthcare. My next question and the last question to Dr. Shyam Agrawal is, what are the, so it is an open question that I will take from all the panelists. If we are talking about the future of diagnostics when it comes to breast cancer, what kind of device, what kind of imaging tool, or what kind of equipment would you like, which serves all brackets, all purposes? And what are the key trends that you see in future that you would like to have for your, benefit in your practice regarding this?
So I think a lot has been spoken about the testings which need to be performed to detect breast cancer early. But I think suffice it to say, the test has to be simple, it has to be cheap, it has to be acceptable to the society, and it should be reliable. So I think if you fulfill those four criteria, I think you'll be able to detect breast cancer early. Today, the mammography, as has been said, I mean, is available, but only to a limited number of women, especially in the metropolitan cities. So I think it's an unmet need. And that is the reason that we detect cancers so late, as in contrast to the figures which we get from the Western nations. So I think it's a huge unmet need. Awareness, as was pointed out by Dr. Shikha, is the key. But I think the simplicity of the test is also very important. I wish there is a simple blood test, I mean, which could pick up breast cancer early. But then I think there are some kind of research going on for developing such kind of blood tests by which you can develop the circulating tumor cells or the DNA of the breast cancer in an individual. But I think it still is, several years away. At this time, it is only the imaging which one needs to focus on. Thank you.
Thank you so much, Dr. Agrawal. My next question is to Dr. Manjri. Ma'am, when it comes to, prognostics and, detecting the recurrence of tumors early and this aspect of breast cancer science, what are the challenges that you foresee coming up in this space, and what are the opportunities that you foresee in this space?
Sure, yes. So I would say one of the challenges that we face is heterogeneity. Apart from what Dr. Sham and Dr. Shikha has already mentioned, especially in testing prognostication disease, it's the heterogeneity of the disease. Breast cancer is not uniform. So many patients have pockets of DCI, I mean, early stage, and pockets of aggressive tumors, pockets of HER2 negative, HER2 positive. So that heterogeneity is if there is a way to develop a fantastic imaging tool which can tell you everything at once, or prognostic test which can understand the heterogeneity really well, that will go a long way in treating the patient better. And also, other thing I would like to emphasize on is really precision medicine. So today, it's still largely we are doing one size fits all kind of treatment, but in going forward in future, if we can really do an approach where we really have precise treatment plans for each patient in terms of if they have aggressive tumors, which therapies, additional therapies one can get based on prognostic tests. So so prognostic test in short will be the kind of predicate test for the additional targeted tests to come. So we need to really get there. Prognostic test can also be the route for developing better targeted drugs. Like, for example, Cannasus-based is against 5 biomarkers. Some of them are membrane associated, and one can make targeted drugs against those same proteins, the biomarkers. And that way we become predicate for our own, for the drugs to come, only to be given for select high risk patients. So these are some of the advances that prognostication that lies in front of all of us. Yeah.
Thank you so much, ma'am. Just on the same note, you said understanding heterogeneity of the disease is one aspect that imposes some sort of challenges. And as the technology is integrating with artificial intelligence and machine learning, how do you foresee advanced machine learning, helping in solving that heterogeneity issue?
Yes, I think so deep learning is one of the technologies which is AI goes AI based and so on. So today we are really looking at things that we know, but there is a lot of information that deep technologies can really understand. So even a simple slide, that H&E slide, to understand the tumor whether it's malignant or not, there's a lot more hidden information than today what pathologists are using to prognose the disease, whether it is malignant versus not. And deep tech kind of technologies would, in my opinion, would be helpful here to really understand the heterogeneity, not only from the slide, but from the 3D imaging, from tomosynthesis, or whatever the latest and the greatest imaging technologies are available. I think these are the ways to really get to the bottom of how heterogeneous is that particular tool.
Thank you so much, ma'am. My last question is to Dr. Shikha. Ma'am, we have been discussing all different aspects of detection and screening around breast cancer and the diagnostic tools. So how do you feel the public-private partnership aspect come into play to help with the private organizations? The government is there to expand and upscale and support, and also for the government, the private organizations giving technology, the research backup, and etc. So what would be the future of imaging and diagnostics when it specifically comes to breast cancer space that you can envision?
Yeah, so I will start off from where Dr. Geeta left, and Dr. Manjari also spoke. See, we have the equipment, we have the technology available, but we have to reach that technology and target a large amount of audience. We are heavy on population, but the resources are limited. So what needs to be done? A lot of work needs to be done on artificial intelligence, in which the public-private partnership can help. Basically, how does artificial intelligence function? It reads a large amount of data. A large amount of data is fed into the computer, and it takes out those points on which it builds up. So we need a large amount of data. We as an organization, my own organization, Mahajan Imaging, we do a lot of work on artificial intelligence, for which we need data. So we have a lot of centers. We collate all the data and we feed it on the machine, which will come out with these protocols on which, on a single mammographic image, it will be able to predict this lady is going to have this type of breast cancer so many years from now on. So it can predict that kind of a thing. So we have to collaborate with government. We need to pool in all the data to one area, do machine learning, and when artificial intelligence can be used, then it can compensate for lack of doctors, lack of training, in the sense that it can triage. We can have huge number of population screened. It can be triaged, and where a second read is needed, that's where the human touch will come, which will reread, those small number of imaging that needs to be read. And that's how the future should be. And that is the only way we can detect cancers early and help patients. So AI is a very, very important tool. Of course, simultaneously, the technological advancements keep happening on the imaging techniques that we have. But AI, integrated with AI is actually the trick. And more in future, once AI is integrated with our science, is when we will best be able to help the population.
Thank you so much, Dr. Shikha. Before I let all the panelists go, one key takeaway message very quickly from all our panelists, as we are commemorating the Breast Cancer Awareness Month. So key takeaway messages to all the viewers that are watching. Let us start from Dr. Geeta.
Sure, I would just again say early detection is very, very, very critical. Do not ignore, don't wait for it to show up. You show up in front of a screening device, find it yourself.
Thank you so much. Dr. Manjari, I'm yours.
Yes, once again, my request would be get diagnosed early. It is not a taboo anymore. The earlier you get diagnosed, the better it is for you to manage the disease.
Thank you so much. Dr. Shikha?
I would like to say to every woman, prioritize yourself. If you are healthy, your family stays healthy because you are available to take care of your family. So prioritize yourself, get detected early, be breast aware, know the feel of your breast, examine yourself every month. So the earliest sign that you can see that something is abnormal, you reach a doctor, and that's it. Prioritize yourself.
Thank you so much. With that, we wrap up this very insightful discussion on the topic of advancements in breast cancer detection, a new era in early detection, an initiative of Integrated Health and Wellbeing Council with Rapid Global Cancer Alliance being powered by Novartis. I would like to thank all our esteemed speakers for taking out time from the busy schedule, imparting us with wealth of knowledge and information on this topic today. Thank you so much, Dr. Sham Agrawal, Dr. Geeta Manjunath, Dr. Manjari Bakre, and Dr. Shikha Panwar for taking out time. Thank you so much. I would also like to thank our partner in the activity, Novartis, for this brilliant initiative for raising awareness around different aspects of breast cancer. Thank you. And I would also like to thank all our audience for staying with us till the very end. I hope the session was as informative and insightful it was for you as it was for us. With that, we sign off now. Stay happy, stay healthy. Thank you.